some logistical matters here. We do want to hear from you during the webinar today, so there's a couple of different ways that you can interact this morning. The first is to type questions into the question pane at any time during the presentation. So there is time set aside at the end of the webinar to answer your questions, but no need to wait to the end to send them in. Go ahead and type them as you have them. We'll organize those and get those to our presenter at the end of the webinar this morning. There's also going to be a couple of interactive opportunities and some early morning math for you. So if you have a calculator handy, that will be helpful. And you can use the chat to answer questions from our presenter as they occur throughout the presentation. Before I turn things over for the presentation this morning, I want to tell you a little bit about this Patient-Centered Primary Care Institute. The Institute is a public-private partnership launched in 2012 with the support of QCOR and through a partnership with the Oregon Health Authority. Together with the experts we partner with, our goal is to get primary care practices connected to technical assistance resources as they work towards a patient-centered primary care home or medical home model of care. We want to make sure we get information to practices at all stages of transformation, help them build capacity, create alignment, and be an ongoing support for transformation and quality improvement resources in Oregon. Encourage you to visit our website if you haven't, where you'll find a lot of information, including webinars like the one today, recorded and available for you to watch. Like I mentioned, the Institute aims to help primary care practices achieve recognition as primary care homes through the state of Oregon's PCPCH program. You can read more information about the PCPCH program, access the updated 2014 standards and accompanying TA guide through their website. I will say later this week we will be announcing the release of some online learning modules around the PCPCH standards. So be sure you're on the Institute email list to get notification of those when they're available. Without further ado, I am going to introduce Mindy Statlander, who is the Clinical Systems Innovation Manager at Care Oregon. Since 2004, Mindy has worked in primary care innovation, quality improvement, and data analysis for safety net health centers and in academic research settings. She worked with Multnomah County Health Department in the development and implementation of the medical home across 8 primary care clinics and 13 school-based health centers. In her current role, Mindy leads Medical Home Technical Assistance Program, Patient and Population-Centered Primary Care, or PC3, and the development of innovative payment methodologies for primary care. The PC3 program works with more than 70 clinics in 4 CCOs and through the Patient-Centered Primary Care Institute. Mindy received her MPH in epidemiology with a certificate in program evaluation from the University of Pittsburgh, and we are in wonderful hands hearing from Mindy this morning. Mindy, you can take it away.
All right, good morning, everyone, and thanks to the Institute for having me. So this morning, what we'd like to do is talk a little bit more about empanelment and continuity and what you do with it after you've all filled in every patient in their little PCP field in the EHR. So we want to talk about what an active panel is. Hopefully by the end of today, you'll be able to calculate an ideal panel size. And we'll talk a little bit about how utilization of clinic services impacts supply and demand and how you can address that with continuity and contingency planning. Kate mentioned at the beginning that we're going to try to do some math on this webinar. This is the first time I will do this in a webinar setting, so we'd really love your active participation and your feedback at the end about how this worked for you. So everyone out there, I know that it's 8 in the morning, but if you grab your cup of coffee and your calculator, which everyone has on an iPhone or a smartphone, it would be great. There will be a couple of places for you to chat in. So again, let us know how this works for you. So what we're going to do is focus on how you actually operationalize 3 of the standards related to continuity. So we're going to talk a little bit about standard 4A, how you assign an active patient to a personal clinician or a team, how you track, improve, or meet a benchmark in the % of patient visits with an assigned clinician or care team, and how you demonstrate a mechanism to reassign administrative requests, prescription refills, and clinical questions when a provider isn't available. These standards are all very much interrelated to each other, so we decided to combine them for today. Okay. So empanelment is a way that you can start allowing patients to see their own PCP and sort patients into different populations. It's a made-up word, which means to ensure that every patient has an assigned primary care provider. The most basic way of doing this is most EHRs have a PCP field, some of which require you to fill it in. So at the very basic level, empanelment is starting to get that field populated with who the patient actually believes is their primary care provider. But empanelment can be about much more than just that assignment and getting that field filled in. What it can do for you is to allow you to start understanding who the group of patients are that you take care of, both people who come into the clinic, so you can really easily validate that those patients have a primary care provider, but also start to let you reach out to those who don't come in, because you're starting to understand who the population is that you're serving. It can allow the provider or the care team to customize their services to the needs of their clients. If you understand who the group of patients that are assigned to each provider or team are, they might look a little bit different across the clinic. One pediatric practice might not look exactly the same as the other. One might be filled with more well newborns and tiny babies, and the other might be largely composed of adolescents. And so the process of empanelment and grouping patients into populations will allow you to start seeing the characteristics of those clients. We're not going to spend a lot of time talking about this today, but empanelment can also start to drive data reporting. So when you do reporting out on quality measures that you're required to do for various reporting entities and for your own internal quality improvement purposes, empanelment allows you to attribute each patient to a particular provider and allows that team to be able to work on improving the gaps in care of chronic disease needs of those patients. The other thing at just a very basic level is if we believe that the medical home, if a core part of that is providing a relationship between a team of people who take care of that patient and an informed patient, then we have to figure out a mechanism for that to happen within our system. So what we're going to do is just walk through each of those three standards and talk about a couple key areas within each of them. So the first thing we're going to spend time talking about is assigning an active patient to a care team. So we're going to spend a little time talking about active and what that means. So an active patient, the reason that we say not just patients, we say active patients, is because it's a way to identify the group of patients that a particular team or provider is accountable for, that they orchestrate and coordinate the care for that patient. It doesn't necessarily mean every patient who's come in the last year, 18 months, 2 years, we're going to talk about that in a second, because you know that sometimes patients move, they transfer care, they leave your practice for lots of various reasons. So you really want to understand who you are actively engaged with, not people who have moved or who transition clinics. This doesn't have to match the enrollment or your new patient definition. So just because somebody isn't on your active patient panel doesn't mean that you would have to treat them as a new patient when they come in. Say they haven't had a visit in 2 years, and you still want them to be able to follow all the regular established patient protocols for registration. Excluding them from this active definition doesn't mean that you can't do that. There are a few different definitions that people use commonly. One visit in the last year is an active patient definition, provided you haven't moved or transferred care. Also use one visit in the last 18 months and one visit in the last 2 years. So we're going to talk a little bit about why you might choose each one of those in a second. And then thinking about this is actually really important because it's most useful when it's consistent across all your definitions in the PCPCH. When you're looking at clinical measures, this active patient definition should be the same when you're doing panel size calculations, when you're measuring continuity. Because if you are deciding who you are accountable for, you want that population to match across all of these different ways that you measure your practice. The other thing is that the active patient definition should be regardless of payer. So it doesn't matter that they are a Medicaid patient, if they are a commercial patient, or they're completely uninsured. You want this definition to encompass to be payer agnostic. How you treat them within your practice doesn't affect or doesn't change based on the payer status. All right, we're going to try a little chat question. So when we talked about one visit in the last year, one visit in the last 18 months, one visit in the last 24 months, how do you think you would decide? What would you consider in making a decision about how you're going to define an active patient population? So which panel size definition you would use? How would you decide? If folks could type in any early morning thoughts into the chat box. So if you're sitting there thinking about how you might decide if you're going to make your active patient definition one visit in the last 12 months, one visit in the last 18 months, or one visit in the last 24 months, what kinds of things would you consider in making that decision?
One person who said how long the clinic's been established. That's
great. So if you've only been open for a year, that would definitely change the way that you think about who your active patient population is. Maybe if one more brave person could volunteer a suggestion.
A couple other people have said that they think the last 24 months or patients seen in the last year, but not necessarily why. And then someone else just wrote and said, although we use 18 months, a visit in the last year could be nice because that is what most reporting measures are based on. Some others have said type of practice. Someone else said size of the patient base.
Okay, these are great suggestions. Thank you guys so much for writing in. So you guys have incredibly accurate thoughts about this. So what the size of your patient population is, how often they actually come in. The other thing you can do is use data. So this is a completely made-up data set. This is looking at when patient's last visit was. And there are 250 patients who have had a visit in the last 3 months, almost 300 in the last 3 to 6 months. You can see that it starts to drop off after 12 to 15 and 15 to 18 months. So you'd capture about 80% of your patient population if you cut it off at 12 months, and you'd get up to about 90% if you cut it off at 18 months. So you could also look at your patient utilization patterns and see how many people you would be leaving off of your active patient definition if you just limited it to 12 months or 18 months. The other thing, and I think somebody said this, that you could consider is the scope of your practice. So pediatrics, for example, you get to a point where kids are only coming in every year, and you might cut off a lot of people for whom you'd want to do outreach if you made a hard stop at 12 months. 18 months would probably be better in that perspective. So you guys are thinking about all the right things and just making a decision based on what's best for your practice and your patient population. It's what you need to do. So then we're going to talk a little bit about this personal clinician or team part of Standard 4A to talk about what an active patient definition is. Now, who are we assigning them to? And this is, again, you can customize this to the particular needs of your practice. I'm going to have a chance for you guys to chat in again here in just a second. I'm going to give a description of 2 clinics, Clinic A and Clinic B. Clinic A has 6 providers, and the providers rotate covering for other providers who are out of the office that day or on vacation, so they all cover each other. In this particular clinic, the MAs are paired with a provider, so they have that great Tom Boneheimer teamlet model of primary care. The front desk and the scheduling staff serve all the patients, so they have kind of a united front when they come in. And this particular clinic is lucky enough to have 1 nurse who covers triage for all the providers who need it. So in thinking about the standard, do you guys think that this clinic, Clinic A, should use personal clinician assignment or a team assignment? What might make more sense for that clinic? Would we want to assign the patients to each individual of those 6 providers, or would we want to call them a team because they do work together to cover each other?
So 2 people have wrote in and said personal. We have 1 that's saying team. Cue the say team. All right, we're three for three on each.
We're tied. Okay. So in this clinic, it would be most appropriate to assign patients to a personal clinician. These guys do act as a team across the clinic. They're helping each other. They're supporting each other. The providers are all covering for each other. The front desk supports everybody. But in this particular case, what the PCPCH standards ask for and what makes most sense when you're dividing patients up into smaller subpopulations is a team that is definitely less than 6 primary care providers. So for this clinic, it makes the most sense to assign patients to an individual provider. Also because this clinic has a real strength in this MA provider dyad, and so if you assign patients to each of those 6 providers, the provider and the MA can get to know those patients really well, and the patient can rely on both the provider and the MA as part of their core support team with all the rest of this wonderful staff supporting those patients as they go through the clinic. All right, what about for Clinic B? So this clinic has 6 providers, and each of those providers have an assigned practice partner. The practice partners cover on each of the providers' days out, so the coverage isn't spread across all 6. It's limited to the 2. They have 2 MAs that are assigned to each provider pair, and then the way that they've organized their front desk staff is that they have 1 front desk staff assigned to each provider pair, and those front desk staff go to each of those provider pair team meetings. So what do you guys think about this one? Should we assign to a personal clinician, 1 to each of the 6, or should we assign as a team to each of these dyads?
Everyone writing in so far is saying team.
Great.
Team.
Great. So this might be a slightly more obvious example, but I hope that you guys see the difference between Clinic A and Clinic B. Clinic A definitely works as a team. They do a lot of teamwork and they work together, but in the way that that practice is organized, it makes most sense for that to be a personal clinician. In Clinic B, it makes most sense because the way that they operate is in these smaller teams. It makes most sense to do a team assignment. So in real life, practices are somewhere probably in between Clinic A and B, and you'll have to figure out for your practice what makes the most sense. But hopefully this gives you some good markers for how to judge. When you choose a personal clinician or a team in your assignment, this should be consistent across multiple standards. So when you report on empanelment, as in 4A, we're going to talk about continuity in 4B. Keep it consistent across all of those. And it should reflect how the practice operates and coverage. You heard me describe their scheduling protocols, how they do their vacation planning, and in the patient relationships. So who is the core part of the team that a patient has a relationship with over time? These 4 are the key steps in empanelment: figuring out what your supply and demand is within your practice, figuring out a way to assign patients to a primary care provider, having providers and teams within the clinic review that list and validate it for you, and then a step in risk adjustment. And we're not going to spend any time today going over this because there are a couple of great resources out there on the web. The Mark Murray et al. In 2007 in the American Association of Family Practice Journal has a great description of how to do this. There's a great Safety Net Medical Home Initiative article on empanelment. Both of those are linked to here and on the Patient Centered Primary Care Institute website, so you can go there for more detail if you are in the place where you're just doing empanelment. These are great resources. But what we are going to talk about today is panel size and ideal panel size. So empanelment is the process of creating a panel size, right? It's the actual count of patients that are assigned or belong to a team or a primary care provider. You can do some adjustment. You guys have probably heard about weighting by age and gender or patient complexity or specialty. You can adjust the panel size if the practice is really variable enough. But basically what empanelment does is allow you to get a clean panel size, the count of patients that are assigned to each primary care provider or team. But the other thing that you can do with this is to calculate an ideal panel size. So you know what it is, but what should it be? So an ideal panel size is how many patients a team or a primary care provider can handle based on how often they're in clinic and how many visits they see. This is based on FTE, the team or provider productivity, and patient utilization. All those factors are really important. This is going to look, just incidentally, this is going to look really different in a world that is not fee-for-service, where we have more telephone visits and we have group visits and we have e-visits, but most of us are still operating in a fee-for-service environment, and so because it's kind of cleaner math, it's a great way to get introduced to this idea and to calculate it for yourselves, and then we will all learn together as a state as we move from visit-based payment to value-based payment what panel sizes look like. I want to talk for a minute about why you might bother setting an ideal panel size. It's a really useful way to balance team or provider workloads, and it makes it really objective. So you probably all are in practices wherein some providers and teams feel really overwhelmed, and some providers and teams are like, bring it on, I can take any amount of patients that you want to throw at me. And what this does is take the perceived experience, which is completely valid, but it provides another lens based on the math of how many patients are coming in and how often and who's responsible for what. So it gives you another lens to look at workload distribution. It can help to meet productivity goals. You need a certain pool of patients in order to generate the amount of visits that you need to see to keep your clinic doors open and the lights on. So it can help you figure out what that patient pool looks like. Most practices are really good at figuring this out kind of intuitively, how many patients they need to add in order to get the demand that they want, but this allows you to do it in a way that's mathematical. We talked about how a defined population is useful to improve continuity and meet clinical outcomes. If you know who they are, it's easier to do outreach for them. This kind of thing can also allow you to add new patients at a really steady rate, so you know how close you are to getting full, and also can help you think about when you might need to start planning for adding a new provider or a new team for those practices who are able to do that. So the ideal panel size, this came from Mark Murray, who wrote about panel size extensively. The model comes out of Kaiser in the late 90s, has been adapted all over the place. But this is a really actually simple and kind of elegant equation. So you should have the visits that a provider or a team is able to give in a year should equal the number of visits that a patient on a panel need in any given year, right? And so what this looks like in the math is how many days in clinic a provider is in for a year times the amount of visits they have per day. So this gives you the amount of visits that they have in a year to give. And then you have a certain number of patients, so that's your panel size, and they come in a very predictable amount of times per year. So again, the total amount of visits that a provider or team has available on their schedule in a year should equal the total visits that patients create. And so this is just sort of basic algebra. You can solve for panel size by dividing. You get days in clinic times visits per day over average visits per year, and that will give you your ideal panel size. So this is the point in the day, in the morning, where you get out your calculators. We're going to try to calculate this for a pretend clinic. And just a second. Okay. So we have a clinic with 4 providers. We're going to start by calculating that numerator number. So days in clinic per year times visits per day, or productivity. So we have 4 providers, one who works half-time, a magical provider who works 1.0, 0.8, and a 0.6. You can see their current panel size. So that's just the count of people who have that PCP assigned to them. And then their PCP visits per day. So what the productivity expectations are for each of those providers. So A, B, and C have the same standard set of 18, and provider D is a new provider, so they are only expected to see 16 visits per day. Then we also want to count the number of days that they're in clinic per year. So this is just something you can either do by policy or you can do by looking back over the past year's experience. For many of the safety net clinics, which is the only published standard that I know about, most folks use 210 visits days in clinic per year. So this takes out sort of the average amount of vacation time, CME, sick time. You want to subtract all that out and figure out how many days in clinic a provider is present for a year. And to be clear, this is for a 1.0 provider. We're going to adjust for that specialty a little bit later. And then the reason that you might not want to use the same amount of days in clinic per year is if you have some really well-established providers who have a lot of vacation time. So that's provider C. They have a really big current panel. They have a lot of vacation time. They're really established. So we want to use a little bit less days in clinic per year so that we get a really good estimate of what they're able, what their supply really is. So what we're going to try to do is calculate that numerator. So we're going to get out our calculators and multiply the days in clinic per year times the visits per day. And we're going to do that for provider A. So if anyone could write into the chat box or the question pane what the provider visits per year for provider A would be. So that's visits per day times days in clinic per year. Do we have any takers, Kate?
We do. We have a couple of people writing in. And we've got a webinar full of mathematicians today, or at least probably, because they all have the same answer, which is 3,780.
Perfect. You guys are brilliant. So provider A has 3,780 visits that they are able to see in 1 year. Provider B is the same because it's 18 times 210. Provider C looks a little bit different, 3,420, because, again, that vacation. And then provider D looks just a little bit different because their productivity expectations are a little bit low for now. We're going to give them a little bit of a break as they get their practice started. All right, great. You guys are awesome. So now we're going to take that and focus on the denominator, the average patient visits per year. And so this, you have to go to a different data source. You have to figure out who those patients are that are assigned to each provider. So we have that panel size, that's the total patient column. And then we have to figure out how many visits those patients generated in the last year. Doesn't matter to which provider, but we have to get an understanding about how many times each of those patients were coming in. So for this made-up clinic, I gave you both the total patients and the total visits. So to get average patient visits per year, what we do is, oops, I gave you the answer, is we divide the total the total visits by the total patients. So I'm going to ask you to write into the chat box what the average patient visits per year for provider B is.
All right, some of the same people from before and some new people. Everyone's saying 4.5.
Great, and thank you guys so much for participating. This makes it way more fun. So you guys are absolutely right, 4.5. You guys got this math down. The thing I want to point out here is we're doing this calculation as a means to an end to get to an ideal panel size. But this is a really useful thing to do anyway, because look at the differences in our providers A, B, C, and D. They range from 2.9 visits per year to 5 visits per year. This is really interesting, different either practice styles or patient populations that would be really great for us to understand. Provider D, we talked about, is a new provider who has a lot of new patients, so maybe 5 visits. Because she's getting everybody in and established, and they also have multiple comorbidities, so she needs to bring them back a couple times. Maybe that makes sense. Maybe provider C has a pediatric practice, but maybe providers A and B have about the same sort of family practice makeup, and they're seeing patients a really different number of times. So it, right, wrong, or otherwise, doesn't indicate any good or bad judgment, but it's really interesting and can be a really useful conversation among your provider team to understand what those differences look like. And they really impact what your panel size could look like. Okay, so we're going to take those numbers and we're going to fill them in here. And so now we're going to get to an ideal panel size. We're going to switch to ideal panel size. So how we do this is provider visits per year divided by average visits per year times FTE. So I'm going to show you the first one. It's 540. So if everyone could write into the chat box and talk and figure out the ideal panel size for provider B. So because I couldn't leave it up, the calculation, and show you the grid at the same time, I'm going to tell you what it is. It's provider visits per year divided by average patient visits per year times FTE. Provider visits per year divided by average patient visits per year times FTE. Any takers?
Yeah, we've got a couple of people writing in saying 840.
Oh, you guys are brilliant. 840, perfect. All right, so I'm going to let you off the hook, and I'm going to do the rest of them for you. So provider C is 943, and provider D is 353. So you can see we just went through this kind of simple equation, but it results in a really different panel size, and we customized it to the experience, both FTE and the average patient utilization for each of those providers. So we dialed it in really closely to what each of those providers' panel's actual experience is, which is really cool. And now we can just understand the difference. So we have one provider who has quite a bit of room still on their panel, provider C, and we have one provider who's really over-paneled. Their ideal panel size is way bigger than what their current panel size is. So this would help us understand in, this ACA expansion land that we're all living in, where does it make most sense to send the majority of new patients, and where does it make sense to really back off and protect the provider's time because they're committed to the patients that are already assigned to them. So again, this can be a really useful exercise understanding the practice utilization patterns and to start understanding who's full and who's not, and when to not assign so many new patients to a provider, and when you can add patients to the panel. Also helps you understand your capacity at a clinic level. So this clinic is, getting pretty close to full across the clinic. If they have the capacity and the rooms to be able to add another provider, it might be a good time for them to start thinking about it because provider recruitment takes so long. All right. I really appreciate your guys calculating the answers to this, and hope that you find this useful in your own practice. So we're going to shift a little bit to talking about maintaining empanelment. So if you use this for an ongoing understanding about your panel size and who's full, and you use it as a way to regulate the way that new patients come into the practice, you have to maintain that PCP field in a way that is really real time. So you can implement a process for assigning a PCP adder before the first visit. You can have your check-in staff, whoever is checking in the patient for a visit, implement a process for validating that PCP and making sure that the patient knows who they're assigned to and is in a good spot with the relationship with that provider and team. You can also identify unassigned patients monthly and figure out a process for assigning those patients if you missed somebody as they were coming in. The other good thing to take a look at when you're thinking about maintenance is making sure you look at those providers who are no longer at your practice. Many practices that we work with have a provider whose name is provider unassigned, and many patients end up assigned to that provider. So taking a look, on a quarterly basis or biannual basis to make sure that all the providers to whom you have assigned patients are, in fact, providers who work in your practice. There's also a couple of policies and procedures that many clinics find helpful in implementing if you're going to use panel size on a regular basis. So if you are using that assignment to manage demand and how patients come in for visits, you need a process for how to change providers, whether based on patient preference or if a provider needs to move that patient for patient complexity reasons or because they need a different scope of practice. Understanding how to do that and having an agreement among all your staff and an explicit policy for your patients is really helpful. It's really good to have a policy about how many new patients you get based on the percentage that you are full, how you make decisions about how to open and close a panel. And this is a really critical one, a process for when a provider leaves. What's your expectation of what a provider does to kind of clean up and close out that panel and make a really good warm handoff to other providers in the practice or to a new provider? So having discussions at your clinic about the standards that you would use for each of those areas can be really helpful. All right, we're going to shift gears a little bit and talk about continuity and why it matters. So continuity is another one of these appropriated words. Google defines it as a consistent or an unbroken relationship over a period of time, and we're applying that now to the relationship between a patient and a provider. The reason, or a team, the reason that this is important is in the literature, it's supported that patients need less visits and less touches. If you have a good relationship over time, clinical outcomes are better if there's a consistent relationship. It's a better experience of care because the patient doesn't have to repeat their same story and their medical history. And it's also more satisfying for practices, for providers. Most folks went into family medicine because they valued that relationship with a patient or family over time. And so figuring out a way for us to make that happen in our current busy practices can be a really big job satisfier. So we're going to talk about 4B. And the key operational phrase here is, again, that assigned clinician or care team. So we're going to talk a little bit about how you would think about continuity differently based on our two practice examples. So just as a brief description, there are two ways that you can measure continuity. The first of which is how the PCPCH standards ask you to report the data for the continuity measure. So this is the percent of time patients have a visit with their assigned provider or team. So it's continuity from the patient perspective. But you can also flip that around and talk about how often a provider or a team in clinic have visits with their own patients, because we just talked about that the relationship over time is really important for job satisfaction. So it's important to understand what the provider or team experience is like too. Okay, so we're going to go back to our Clinic A and Clinic B examples, and we're going to figure out how to calculate continuity. So you all said that we had some plurality for Clinic A, that we would calculate that by individual provider, because even though the clinic works as a team and they help each other, the relationship really is with the individual PCP and the MA dyad. So when we calculate continuity, we want the calculation to reflect that. So for the PCPCH standards, they ask you to report the visits in the last 12 months, calculate continuity based on visits in the last 12 months. So that's what we're going to do. Provider A had 2,835 visits of their panel to themselves. And then they had 3,780 visits in the last year. So for continuity, the calculation is visits to the primary care provider divided by the total number of visits. So I calculated it for you for PCP A. Can somebody graciously calculate it for provider B?
All right, I think everyone's getting their calculators out. Let's see who our gold star mathematician is.
I think that there should be some reward for that.
There are some people who've been consistently doing these here. Okay, we have 85% coming in.
85%, that's right. You guys are great. I filled in the rest of them for you. The reason I left provider C blank is because in this practice they had some provider turnover in the last year, and provider C is a locums provider who's helping to fill in. But the clinic has made the decision that that person is just a fill-in provider, and they know that they're going to be able, they're very lucky, they know they're going to be able to recruit another full-time provider very shortly. And so when we do the calculation, we leave their visits out of the continuity calculation. So they have generated visits, that 2605 is probably, I'm going to just go to provider A, for example. Some of those visits to other providers, 945, probably that provider C provided some of those visits, but because they're not an assigned primary care provider, we're not thinking of them in that way. And what we're really getting at is measuring the amount of time that a patient gets to see their provider. Then we, those visits count as visits to other providers, not to the PCP. So that's why we've done it that way. So now we're going to take a look at Clinic B. So this is the clinic who has 6 providers, and the providers are matched to each other. So they have 3 teams. Their 2 MAs are assigned to each of those provider pairs, and they have a front desk staff supporting each of those teams. And so that calculation is going to look a little bit different. So for continuity, we would want to understand both how many visits there are to the primary care provider, so provider A, it's 2835 that were directly to them, but then 502 were with their practice partner, provider B, and then 443 were visits to other providers. And then again, they had that same 3780 total. So for Clinic B, if you have a team model, it's visits, the way that you calculate continuity is visits to the primary care provider plus the visits to the practice partner divided by the total visits. So again, it's going to look a little bit different. So for provider A, it's 88%. Let's do provider B.
All right, let's see. Everyone's warming up their calculators.
So visits to the PCP plus visits to the practice partner divided by the total visits.
98% is the winner.
98% on the money. So you can see how this calculation is really different based on how the practice is structured and how the relationship works between the patient and the care team. So I'm going to fill in the rest of these for you for reference. And again, this looks a little bit different because of the way that the practice is organized. Thank you, guys. So we're not going to spend time talking about it this morning. If you have any questions, we are certainly happy to help put up resources. We spent time talking about the patient perspective of continuity, but there's also the provider perspective. So this calculation would look at, of all the time that a provider is in clinic and how many visits they themselves see, how many of those visits are with their patients that are assigned to them. And this can give you a really different look at the experience of continuity in the clinic. It can also give you hints if a provider is over-paneled. So if a provider has too many patients, then they spend a lot of time seeing their own patients, but their patients don't get in to see them quite as often because they're hard to get into. They have too many patients to take care of. So looking at continuity from both perspectives is important, and it can also give you an understanding of your supply and demand. We're going to go through this, and we're going to skip to talking about how to improve continuity. There we go. The way that you can improve continuity is through scheduling protocols. So this is a really great place to do scripting for your front desk staff. To have a panel management policy where you're reaching out and engaging patients, forming the relationship between the MA, the nurse, the front desk staff, and the patients, and figuring out how, when patients come in for visits and when providers need to be there. And this is a great reason to move forward with team-based care, because if you're making the relationship between the patients and those two provider dyads, then an individual provider doesn't have to be available every day of the week. They have a practice partner that they can rely on to help meet their patients' needs when they're not in clinic. So you can provide coverage with a practice partner that way. All right, so for our last standard, we're going to talk about E, which is very much related to continuity. So the PCPCH has to demonstrate a mechanism to reassign administrative requests, prescription refills, and clinical questions when a provider isn't available. And the best way to do this, like I was just talking about, is to think about scripting your front desk staff and to giving some thought to whether a practice partner or a team-based model really makes sense for your practice. So in this scenario, we call this rings of defense. So when a provider is in clinic, then they are able to meet the needs, they and their team are able to meet the needs of the patients on their panel. So clinical questions come back to that MA or to the provider, or if they're lucky enough to have a nurse on staff, and they can sort out the needs of the patients that way. When they're not in clinic, if a patient needs a visit or has an administrative request or a prescription refill or a clinical question, then they can direct that to the practice partner. But in a team-based model, if the actual primary care provider isn't in clinic, often other team members are there. So the other team members who have that very close ongoing relationship with the patient can help support that practice partner in figuring out what that patient really needs. They understand the backstory. They know what's going on in that patient's family life. They've been working really closely with the provider, so have an idea about what the plan is, so they can support that practice partner and they're not out there all alone. And then the third ring of defense, which if a patient really needs to get in, obviously that's the most important thing, and they can go to another provider in the clinic. But having that dyad or that team helps create an additional ring of defense around meeting the needs of patients. There's also a great process called contingency planning that you can go through. So if part of it is the rings of defense, and then part of it is figuring out how administrative requests and refills and clinical questions route through the clinic. So at first they go to the primary care provider, to that person's nurse. If not, if you have a larger team, many clinics have set up pools within their EHR or group messaging so that any member of the team that can take on an issue and get it worked out for a patient can do that whenever they have the time, and it doesn't rely on the front desk staff or the scheduling or the call center to direct the patient to the exact right person. The team can help take care of it, and creates a process for understanding what's going to happen when somebody's out of clinic. Contingency planning is also having a team understand when each other is going to take vacation and to plan for it accordingly so that both providers aren't out at the same time and there's little or no coverage. There are quite a few things that you can do if you have an understanding about who the patients are, how they flow around your clinic, and where the relationships are between the care team and the patient. All right, so with that, we would like to take some questions. Thank you guys so much for participating. Please give us feedback about whether the chat-in and the math part of it was a useful exercise for you. It's the first time we've done this kind of interactive thing via webinar, so please don't hesitate to let us know if it worked for you and how we can make it better. And if anyone has any questions, or Kate's been collecting them over time, we'd love to hear them.
Yeah, I have a couple to get us started, and then welcome everyone else to enter questions into the questions pane if you have them. So a couple of good ones to start us off. The first is, where do the access standards come into play with respect to continuity, or can you talk about just maybe how those may interact?
Right. So what we didn't spend time talking about is understanding the supply and demand, how often any of those patients are going to want to come in at any given point. What happens is that most practices have supply and demand balanced somewhere in their schedule. Sometimes it's 3 weeks out or 6 weeks out or 2 days out. There's always a consistent amount of time that it takes for a patient to get in. So there's a process that you can go through called open access or advanced access scheduling that will allow you to drag that point at which supply and demand are balanced out from 3 weeks from now or 6 weeks from now back to today. And so access standards, how quickly a patient needs to be able to get in to see their primary care provider, really depends on how you organize your scheduling system. Starting with calculating panel size and making sure that each provider or care team has the right number of patients to generate the demand that it can handle is the foundational first step in that process.
Great. So there were a couple of questions around how long does a provider have to be established before you try and determine their panel size, or questions about both a provider coming on board and providers transitioning out of the clinic and how that works, and how you balance those things.
That's a great question. So once you've done this the first time, you'll have a better understanding about patient utilization, which is sort of the key part of the new patient question. If you're getting a lot of, or the new provider question, if you're getting a lot of new patients, you have a new provider, you won't know what the experience of that panel is like until they've been established for a little while. But if you have a good track record of understanding what the average utilization is for the rest of the population of the clinic, you can apply that same number to the new provider. You might expect them to not hit their panel size very quickly because you do know that new patients come in at a more frequent rate than established patients, but you can you can use the experience of the rest of the clinic to determine the ideal panel size for a new provider. That's also going to help you in your planning for expansion or understanding when you need to open or close. For the question about when providers leave, it's a great thing to understand how many patients that provider was accountable for and who in the rest of the clinic is open and closed and where you might be able to slot those patients in if you're not able to hire a new provider directly. If you don't have any overlap but you feel fairly confident that you will have a new provider shortly, you can reassign patients to established providers who are at higher risk and then float the panel over to the new provider. So it sort of depends on what your hiring process looks like and how you want to move through that work. But I would encourage you to think about the exit planning for a provider as they're leaving. So having them go through and risk stratify their patients based on who is much more medically and socio experience-wise complex and figure out a good, clear transition plan for those patients.
Okay, we have had a couple other questions come in. The first is there a reference or a resource that you would recommend for training folks who do scheduling in a clinic, and how do you communicate some of these messages to people doing that work?
That is a great question. I think we have some scheduling protocols that we can send to Kate that she can post on the PCPCI website. This is a critically important thing for the front desk staff and schedulers to understand. We find that scripting works really well. I know sometimes it feels not that fun, but doing role plays in a scheduling staff team meeting, helping them understand what to do in different scheduling scenarios is really helpful. Having the providers participate in that and help communicate why this is really important and that it is important to them is also a really helpful thing to do. So we can send Kate some resources and stick it up on the web for you.
Awesome. So I will, along the lines of posting, a couple of people have asked, and I neglected to tell everyone that the slides and a recording of this presentation will be available on the Institute website. The PDF of the slides is already up. We'll add the recording by the end of the day, and then also get those scheduling protocols Mindy just referenced and make sure those are posted as well. So that takes care of that one question. Someone asked about, you touched on this briefly, but how would this look different from the provider perspective if you were looking at the continuity from their perspective, and what sort of issues might that raise? If you could just talk a little bit more about why you would want to do that and what information you'd get.
Yeah, that's a really fun, great question. So understanding what continuity looks like from the provider's perspective is important because, one, it gives you a sense of the supply and demand and how that relationship is working out, and I'll talk about that more in a minute. And then it's also important to understand, for job satisfaction, to understand what the experience is like from the provider or care team's perspective. Let me go back to the supply and demand part for a second, and I wish I had a graphic to explain this. Actually, I think I do. Is it okay if I flip back, Kate?
Sure is. Okay.
So with all due credit to Multnomah County, this data is from one of their clinics. So the preferred time that a patient sees their own primary care provider is the blue. So that's pretty high. And that's what we spent time calculating earlier. The other way that you can look at it is the amount of time that a PCP sees their own patient. So this is of all of the visits a primary care provider sees, how many of those visits are with his or her panel? And in this case, that number is a bit lower than what the experience of the patient is. So this means that patients are getting in to see that provider as pretty much as often as they want, right? 80% above is really, really good continuity. The amount of time that the PCP is seeing their own patients is lower than that. And so what that tells you is that that provider is a little bit under-paneled. So they're able to see all of their own patients when they come in and then some. So you might think about increasing this provider's panel size. In the opposite scenario, where a PCP is seeing their own patients, like basically the whole time that they're in clinic, but those patients are only getting in to see their PCP less often, that means that that provider is incredibly full, right? The panel is generating enough demand that all the time they're in the clinic, they're able to see their own patients, but those patients are also going to other providers in the clinic. So either they're not in clinic on the days that the patients are coming in for visits, or they are over-paneled, or they don't have enough to FTE. Something about the supply of visits to that provider isn't matched to the demand that those patients are generating. Good. Any other questions, Kate?
And then we probably have time for one more. Could you briefly, you mentioned this earlier in the webinar, but how does this necessarily relate to reporting?
Okay, fun. So what it does is if you are balancing access, if you're starting to understand who the patient population is and you're making a really big effort to get those patients into their primary care provider or the team, then you would want all of your clinical reporting to also match up with that, because those providers and that team is responsible for seeing and meeting the needs of that population of patients. So they're doing it based on this work. When patients come into the clinic, we're figuring out how many patients they can see so that they have the right number of appointments to meet those patients' needs. What our clinical reporting allows us to do is both look at what's happening clinically when those patients come in. Are we looking for gaps in care and trying to close them? Do the right kind of patient education and engagement using our best motivational interviewing skills when they're in the clinic for a visit. But it also allows us to do outreach to patients who are not getting the services that they need when they don't come in. So we're matching what we're trying to manage on an appointment level with what we're also trying to do clinically. And the more that you can align and support the teams in taking care of one single population of patients, the better off you're going to be.
Excellent. This was perfect timing, so I think we'll go ahead and end the webinar now. Give everyone just a couple minutes, like Mindy said, to fill out the post-webinar survey. Let us know how the morning math worked for you. It helps us plan excellent webinars in the future. Thank you to Mindy for sharing all this valuable information with us today. And again, a couple other people asked, a copy of the slides are already up on the website, and a recording will be there at the end of today, along with a couple links that Mindy has recommended and those scheduling protocols that we'll get from her in post as well. Thank you to everyone for joining us this morning, and special big thanks to Mindy for all the great information.